Welcome. In this session we are going to discuss about ectropion, the etiological factors contributing towards ectropion, its various clinical types, and the surgical options available for correction of ectropion customized towards the specific etiological factor. Ectropion is defined as an outward rotation of the eyelid margin, and most commonly ectropion involves the lower eyelid. Outward rotation of the eyelid margin results in chronic exposure of the conjunctiva, leading to conjunctivitis with hypertrophy and keratinization of the exposed conjunctiva, as we see in this picture. Outward rotation of eyelid margin also results in epiphora, and this epiphora occurs due to punctal eversion and lacrimal pump failure. Punctal eversion leads to non-contiguity of the punctum with the tear leg in the conjunctival sac, and also long-standing ectropion results in punctal stenosis and scarring. Lacrimal pump failure occurs in 7th nerve palsy, one of the common causes of ectropion. Horizontal lid laxity, as we will be discussing, is a common denominator for most types of ectropion. Etiological factors causing ectropion include horizontal eyelid laxity, laxity of the medial canthal tendon and or lateral canthal tendon, deficiency of the anterior lamella of the eyelid, that is the skin and the orbicularis layer, orbicularis oculi weakness, retractor dehiscence or detachment, and mass lesions of the lower eyelid. We will be discussing each of these factors one by one. Horizontal eyelid laxity is the central cause behind most cases of ectropion. In contrast, retractor dehiscence or detachment is the central cause behind most cases of entropion. We can detect horizontal lid laxity by 3 tests. One is the snapback test, in which we drag the middle of the lower eyelid downwards and then release it. Normally it takes less than 2 seconds and before the next blink for the dragged eyelid to snap back and oppose to the globe. In the eyelid distraction test, the lower eyelid is dragged downwards, and normally the distance between the bulbar conjunctiva and the lid margin should not exceed 6 mm. Normally, the inferior puncta is not visible, and only in case of medial eyelid laxity, the puncta is visible without touching the lower eyelid. As we will see when we discuss the treatment options for ectropion, medial canthal tendon laxity and lateral canthal tendon laxity are considered separately from generalized horizontal laxity of the eyelid tarsus. To detect medial canthal tendon laxity, the lid is dragged laterally, and normally the puncta does not move laterally more than 1 mm. And to detect lateral canthal tendon laxity, the lid is dragged medially, and normally the lateral canthus does not move medially more than 2 mm. Lateral canthal tendon laxity is also suggested by rounding of the lateral canthus, and when the distance of the lateral canthus from the lateral orbital rim is more than 2 mm. The anterior lamellar deficiency or scarring of the skin forming the anterior layer of the eyelid results in cicatricial ectropion, and this can be detected by the presence of vertical skin lines, limitation of upward excursion of lower eyelid, relief of the ectropion with lifting up of the cheek, and increase of ectropion with wide opening of the mouth. Orbicularis oculi weakness is also another important cause of ectropion, which is called paralytic ectropion. And since orbicularis oculi is responsible for closure of the eyes, the deficiency of orbicularis oculi action is noted by asking the patient to forcefully close both the eyes, and noting that either the patient is unable to completely close one or both the eyes, or there is apparent asymmetry in the force generated by the orbicularis oculi between the two eyes, and this is associated with other signs of 7th cranial nerve palsy, including brow ptosis, loss of forehead and nasolabial folds, and asymmetry of the mouth during smiling. The lower eyelid retractors are made up of the fascia surrounding the inferior rectus and the inferior oblique muscles, which fuse to form the capsulopalpebral fascia, which is attached to the lower border of the inferior tarsus and the inferior conjunctival fornix. And deficiency, dehiscence or detachment of the lower eyelid retractor or capsulopalpebral fascia can contribute to the development of ectropion, although we will find in the next session that this is the central cause for most cases of entropion. And defect of this lower eyelid retractor system is suggested when we find a deeper than normal inferior fornix more than 11 mm away from the lower eyelid margin with redundant conjunctival folds within the fornix. When the lower eyelid in the resting state appears to be higher than it normally is, when the lower eyelid can be pulled upward more easily than it can be done normally, and when there is a decreased downward excursion of the lower eyelid on down gaze. But this factor can be normal even when there is a retractor deficiency. Also, as seen from the conjunctival aspect of the tarsus, a horizontal white line several millimeters below the inferior tarsal border representing the superior edge of the lower eyelid retractor suggests detachment of the retractor. Mass lesion of the lower eyelid may pull the lower eyelid down, resulting in ectropion of the lower eyelid, and mass lesions such as neoplastic lesions may also have associated cicatricial changes of the skin. After discussing the various etiological factors contributing towards the various types of ectropion, we now come to the individual types of ectropion, and the types of ectropion described are involutional ectropion, paralytic ectropion, cicatricial ectropion, mechanical ectropion, and congenital ectropion. Involutional ectropion is the most common type of ectropion and usually affects the lower eyelid, and this is said to be due to the effect of gravity pulling the lower eyelid downwards and rotating the lower eyelid margin. Involutional ectropion is age-related, and the chief factor causing involutional ectropion is said to be horizontal eyelid laxity, with or without laxity of the medial canthal tendon and or the lateral canthal tendon. Defect in the lower eyelid retractor system is also said to contribute towards involutional ectropion. Involutional ectropion usually starts medially, often with initial epiphora due to punctal eversion, and gradually extends laterally. And it is said that the weakening of the canthal tendons and the pretarsal orbicularis results in relative overaction of the preseptal orbicularis, which causes the inferior tarsus to rotate outwards. And in severe lower eyelid retractor defect, complete eversion of the lower eyelids may be found, and this is called tarsal ectropion. Surgical correction of ectropion in a patient depends on the underlying etiological risk factors present in that patient, which can be detected by the clinical examination. The lateral tarsal strip procedure is indicated for horizontal eyelid laxity as well as laxity of the lateral canthal tendon, and we have seen that horizontal eyelid laxity is the most common cause of ectropion, particularly involutional ectropion. And lateral tarsal strip procedure consists of horizontal shortening of the inferior tarsus and its reattachment to the lateral orbital rim. The procedure starts with a lateral canthotomy as represented by these lines with inferior cantholysis, while sparing the superior arm of the lateral canthal tendon. A subciliary incision is also made, and the skin orbicularis muscle flap is lifted from the underlying tarsus. The inferior cantholysis frees the lateral edge of the lower eyelid. The lateral edge of the lower eyelid is then pulled laterally, and the skin of the lower eyelid is marked where it meets the skin of the lateral canthal angle with adequate tension. The portion of the tarsus lateral to the skin mark is freed of the conjunctiva posteriorly, the anterior lamella anteriorly, and the retractors inferiorly. The lateral edge of the lower tarsus is then pulled towards the lateral orbital rim, and the lateral edge of the lower tarsus is then trimmed, so that the trimmed lateral margin of the lower tarsus meets the lateral orbital rim with adequate tension. Then the trimmed lateral edge of the lower tarsus is attached to the periosteum of the lateral orbital rim just below the superior arm of the lateral canthal tendon and above the horizontal line at the lateral canthus. Then the marked area of the lower eyelid skin is attached to the upper eyelid margin where it meets the lateral canthal angle. The medial spindle procedure is indicated for mild medial ectropion with punctal eversion, And medial spindle procedure can be done in addition to a lateral strip procedure if the lateral strip procedure alone does not correct ectropion of the medial eyelid. In the medial spindle procedure, an elliptical block of the conjunctiva and the lower lid retractors are excised 4 mm below the inferior punctum, that is below the inferior border of the lower tarsus. This excision should not be excessive to avoid entropion. Following excision of the medial spindle, inverting mattress sutures are passed through the superior edge of the lower eyelid retractors, then through the lower border of the inferior tarsus, and then through full thickness eyelid below the level of its passage through the superior edge of the lower eyelid retractor to provide an inward rotational effect. Then the ends of the mattress sutures are tied anterior to the skin. When retractor defect is detected, retractor advancement is indicated. As in medial spindle procedure, a strip of conjunctiva and redundant subcutaneous tissue is excised below the inferior tarsal border but along the entire length of the eyelid. Then the upper edge of the lower lid retractors are reattached to the inferior edge of the tarsus with rotational sutures as shown but along the entire length of the lower eyelid. Full thickness pentagonal eyelid resection is indicated in horizontal eyelid laxity without significant canthal tendon laxity. And if this horizontal eyelid laxity is associated with mild medial ectropion, full thickness pentagonal eyelid resection can be combined with a medial spindle procedure, and this is called the lazy T procedure. In the full thickness pentagonal eyelid resection procedure, an incision is made vertical to the eyelid margin to the inferior tarsal border. Then the two edges of this initial incision are overlapped to assess the extent of resection of the lower eyelid required. Then a second similar incision is made vertical to the eyelid margin up to the inferior tarsal border. The two incisions are joined in an angular manner at the level of the inferior fornix. The defect is then repaired as described in the session on eyelid trauma. Tightening of the medial canthal tendon is rarely done but is indicated if there is significant laxity of the tendon. The anterior and the posterior arms of the tendon are reattached to the anterior and the posterior lacrimal crests respectively. This procedure is rarely done because of its associated risk of damage to the lacrimal apparatus. Paralytic ectropion occurs due to a 7th cranial nerve palsy, and the paralytic ectropion of the lower eyelid is associated with lagophthalmos of the upper eyelid. Associated loss of corneal sensation due to an associated damage to the 5th cranial nerve must be ruled out, and this is very important to remember because it significantly worsens the prognosis for the cornea. This kind of a situation usually arises in patients who have undergone surgery for a brain tumor such as a cerebellopontine angle tumor. Neurological evaluation is indicated when the cause for the underlying 7th cranial nerve palsy is not known. Treatment of paralytic ectropion includes temporizing measures such as lubricating drops and ointments, taping the eyelid shut, and moisture chambers. Long-term measures for paralytic ectropion include tarsorrhaphy, medial canthoplasty, and vertical lower eyelid lift. Tarsorrhaphy is a very important procedure to know, which reduces the horizontal length of the palpebral aperture. Temporary tarsorrhaphy can be achieved by directly suturing the upper and lower eyelid margins together, or by injecting botulinum toxin in levator palpebris superioris muscle. In permanent tarsorrhaphy, adjacent areas of upper and lower eyelid margins are deepithelialized, sparing the cilia, and a 1 mm wide strip of tissue is removed from the mucocutaneous junction of adjacent areas of either eyelid margins. The adjacent raw areas are sutured as shown here, and the suture should be partial thickness through the raw areas without passing through the conjunctiva, thus preventing irritation to the cornea. Medial canthoplasty is indicated for medial paralytic ectropion. In medial canthoplasty, the two arms of the medial canthal tendon are sutured to each other, and the procedure starts by securing the upper and the lower canaliculi with probes. Then two linear incisions are made one along each mucocutaneous junction of the upper and the lower eyelids, and these incisions extend from 1 mm medial to the puncta up to the medial canthal angle where they meet each other. The two arms of medial canthal tendon are then exposed by elevating the skin flaps and by removing a strip of mucosa along the incision line on the two eyelid margins. Then the two arms of MCT are sutured together, including their adjacent orbicularies within these sutures. Some cases of paralytic ectropion require a vertical lower eyelid lift with fascia lata or silicone slings. Cicatricial ectropion occurs as a result of deficiency and/or scarring of the eyelid skin, which forms the anterior layer of the eyelid. In contrast, cicatricial entropion occurs as a result of scarring of the conjunctiva, which forms the posterior layer of the eyelid. Cicatricial ectropion can occur following burn injuries, mechanical or surgical trauma, dermatitis such as in rosacea, atopy, eczema and zoster, and actinic skin damage. Cicatrization can also occur in eyelid malignancies, which need to be excluded if suspected, and in long-standing involutional or paralytic ectropion, cicatrization can also occur. Treatment of cicatricial ectropion includes management of the underlying disease process and correction of the ectropion, which can be done with a full-thickness skin graft or Z-plasty techniques. For full-thickness skin grafting of either the lower or the upper eyelid, the traction is released, followed by skin grafting to increase the vertical length of the anterior lamella of the eyelid. For the lower eyelid, horizontal lid tightening is often required, and the lower eyelid needs to be elevated temporarily with sutures immediately post-operatively. Z-plasty techniques are indicated for small scars causing cicatricial ectropion. Two lines are marked at the upper and lower ends of the scar, equal in length to the scar line, at an angle of 60 degrees to the scar and on opposite sides of the scar. The continuous Z incision is then made through the two marks with the scar in the middle. The adjacent skin is undermined and subcutaneous scar tissue is excised. The apices of the two resulting triangular flaps are attached to the distal ends of the two initial incisions. So the apex of this triangular flap is attached here, and the apex of this triangular flap is attached here. Mechanical ectropion is ectropion of the lower eyelid margin because of a lesion causing the lid margin to move away from the globe. Causes include mass lesion in the eyelid margin or in the conjunctiva, eyelid or conjunctival edema, herniated orbital fat, and pole-defeating spectacles. Treatment is that of the underlying cause. Congenital ectropion is a rare entity which usually affects the lower eyelid but may affect the upper eyelid as well. And causes of congenital ectropion include Down syndrome, blepharophimosis, congenital absence of tarsus, conjunctival chemosis due to birth trauma, and ichthyosis. Treatment usually involves augmentation of a deficient anterior lamella with or without horizontal tightening of the lateral canthal tendon. Complications of surgery for ectropion includes undercorrection with residual ectropion, which usually needs resurgery. Overcorrection leading to entropion often disappears with time, but the cornea needs to be protected in the intervening period. Other complications of surgery for ectropion includes distortion of the canthal angle, distortion, notching or trichiasis in the lid margin, lacrimal apparatus damage, and scarring of the skin or conjunctiva. Thank you for listening.